Most pain procedures are meant to make you feel better. This one is different. A medial branch block is designed to wear off, and what happens when it does tells your physician more than the relief itself. Welcome to the educational channel of Dr. Ryan Kuda, a board-certified interventional pain physician serving the Chicago area. On this channel, we break down the procedures and the research that shape how pain medicine is actually practiced. Today, the medial branch block, one of the most useful and most misunderstood tools in spine pain care. It's misunderstood because patients often expect it to be the treatment. It usually isn't. It's a diagnostic test, a way to answer a specific question before committing to a longer-lasting procedure. Understanding that distinction is the whole point of this video. Here's the anatomy. The facet joints are the small paired joints at the back of the spine that let it bend and twist. Each one is supplied by tiny sensory nerves called the medial branch nerves, the same nerves targeted by radiofrequency ablation, which we covered in a separate video. A medial branch block is a precise injection of a small amount of local anesthetic onto those nerves. If a particular facet joint is the source of your pain, numbing its nerves should temporarily reduce that pain. So the logic is simple: numb the suspect, watch what happens. If the pain drops while the anesthetic is working and returns as it wears off, that joint is likely the culprit. You might wonder why this step is necessary at all. The reason is that back and neck pain can come from many different structures: discs, nerve roots, muscles, the facet joints, and more, and they can feel frustratingly similar. Imaging like an MRI shows structure, but it can't always tell you which structure is actually generating the pain. The medial branch block is one of the few ways to test that directly, and it matters most because of what usually comes next: radiofrequency ablation. Ablation only helps if the facet nerves are truly the source. Treating the wrong target is how you end up with a procedure that didn't work. In other words, the block is the gatekeeper that protects you from a treatment aimed at the wrong place. This is where medial branch blocks intersect with one of the bigger debates in pain medicine. The evidence consistently points to the same theme. How carefully you select patients before ablation strongly influences whether the ablation works. A central question in the research is how strict the diagnostic blocks should be. For instance, whether a single positive block is enough, or whether two separate confirming blocks give a more reliable answer by reducing false positives. This is exactly the issue at the heart of the MINT trials, published in the journal JAMA in 2017, which found little benefit from radiofrequency ablation for low back pain. Major pain societies pushed back, and the diagnostic block selection protocol was one of the main criticisms. We break that whole controversy down in a separate episode. Link in the description. The practical takeaway from all of it: the medial branch block isn't a formality. It's the step that makes the difference between an ablation that's likely to help and one that's likely to disappoint. Skipping or rushing it is exactly how RFA earns its mixed reputation. The procedure itself is quick and done in the office or a procedure suite. You're positioned to expose the area of the spine being tested, the skin is numbed, and the physician uses live X-ray guidance, fluoroscopy, to place a small amount of anesthetic precisely onto the medial branch nerves. It typically takes only a few minutes per level. Then comes the part that's actually the test. For the next several hours, you pay close attention to your pain, usually by keeping a simple log and doing the movements that normally hurt, to see how much relief you get while the numbing medicine is active. That record is the data your physician uses to decide what comes next. Because it's diagnostic, the relief is expected to be temporary. That's not the block failing. That's it working as designed. So what happens after? If the block clearly reduced your pain, that's a positive result, and it points toward a longer-lasting treatment, most often radiofrequency ablation of those same nerves. If it didn't help, that's valuable too. It steers you and your physician away from a procedure that likely wouldn't have worked and toward looking elsewhere for the source. As with any injection, there are risks, and which ones are relevant depends on your anatomy and health. A conversation for a physician who has examined you. The value of the medial branch block is information. Done well, it makes everything downstream more likely to succeed. Bottom line, a medial branch block is a diagnostic test, not a destination. It's designed to wear off, and what it reveals, whether numbing the facet nerves relieves your pain, is what guides the decision about longer-lasting treatment. If a clinician recommends one, a good question is, what result are we looking for, and what will we do depending on how I respond? A reminder before we wrap. This is educational content, not medical advice. Talk to your own doctor about your specific situation. If this clarified things, subscribe and watch our radiofrequency ablation explainer next, since the block is the step that decides whether ablation makes sense.